Well, welcome. My name is Tony Catanzaro, and I'd like to welcome you to the first CME moderated discussion that we're putting on. And this is a moderated discussion of the symposium, the third International Global Symposium on IGRAs. And I'm very happy to have a distinguished panel to discuss the events of the last 3 days. I'd like to ask them to introduce themselves. Dr. Daly.
Hi, my name is Chuck Daly. I head the Division of Mycobacterial and Respiratory Infections at National Jewish Health in Denver, Colorado.
I'm Mike Eisman. I'm a professor at the University of Colorado, and I'm also on the faculty at National Jewish.
I'm Luca Riccardi. I'm Associate Professor of Respiratory Medicine at the University of Modena and Reggio Emilia, Modena in Italy.
So we just finished a 3-day symposium, and you can look at the slides on the website, and hopefully you will, and see them all yourself. But this afternoon I wanted to just have a discussion among the professors that we have here to kind of give you our take on what we heard and discussed over these past 3 days. And one of the messages that I really thought was very important was the concept of latent TB infection. Is one which we in TB Control have discussed a great deal over the past couple of decades, and I think we've made some real progress in understanding and diagnosing and treating latent TB infection. But today, I thought we had some new insights in my mind. So I want to contrast. We've had the idea of these fat, sleeping TB bugs underlying this latent period between new infection and eventually much later going on to disease. But today we heard a lot of talk about a lot of dynamic changes going on. Interplay between infection and phagocytosis and killing of organisms and developing of lesions. One of the most impressive things was the presentation by Dr. Cliff Berry about the dynamic changes using PET scanning. That was more kind of closer, moving closer to active TB. But Dr. Dave Lewinson made a comment that I thought was really interesting. He said there's nothing latent about latent TB. I'd like to hear how the panel thinks about that.
I agree with you. I think one of the more exciting things that we heard the first day was the presentation by Cliff Berry. And this idea that there's this not really static process, but a very dynamic process that's occurring between the organism and between the host immune system. I think that was very interesting, and it makes very much sense because if there really are live viable organisms within the human host that's infected by Mycobacterium tuberculosis, it makes sense that there's this battleground that's occurring and that it's going to fluctuate from day to day who's winning that battle.
I think you can think about it along a continuum. I suspect there are cases in which latency implied by not actively replicating in a consistent way. There probably are patients who have tubercle bacilli in their body which are sporadically active and may just propagate themselves over years and even decades but cause no manifestation. In other individuals whose immune system may not be as strong, it really represents a closer to the surface struggle between the immune system and organisms that replicate or suppressed and may be close to breaking through into clinically active disease. So I think of it still along a spectrum in which latent has many implications, but I think of it as sporadic dormancy, sporadic activity.
Right, I agree completely, and that's a concept which is becoming more and more true as far as we advance with our understanding. And forgive me, Tony, if I jump to the last day for one moment.
Go right ahead.
Actually, we learned today from the WHO that without targeting latent infection, we will never get rid of TB. That means something to me. So the epidemiological model tells us that that's a real pathological state, it's a real disease. If we are not going to get rid of latent infection, we are not going to get rid of active disease. So even the mathematical model and the epidemiology tells us that clearly the link between active and latent disease is just a continuum. And without getting rid of one, we are not getting rid of the other.
You're right to jump ahead, and I was shocked about that as well. We had a wonderful presentation with a mathematical model saying, okay, let's imagine we could treat tuberculosis in 10 days with a treatment that's 100% effective. It was shocking what a small impact that would make on the epidemic that we're suffering with.
Well, the presentation by Abu Radad was actually very eye-opening because I had not seen it presented this way, that mass treatment or mass screening and treatment for latent infection would be one of the most effective strategies in terms of global tuberculosis control. I agree, it was a very impressive presentation.
I thought Dr. Rickelti's presentation regarding the comorbidities was very enlightening. Maybe you'd like to expand on that a little bit today?
Yes. Yes, I think the world actually is quickly changing, and in particular in the most, let's so-called high-income countries. The medicine of today is becoming more and more a producer of immunosuppressed. So any drug, a new drug, they just think drugs for rheumatoid arthritis or for scleroderma or for cancer, that actually cure people, but at the price of producing immunosuppression, at least a temporary immunosuppression. And in that time log, it's important to prevent reactivation of latent infection. That's crucial. For efficacy of new treatment of, let's say, the cancer is a paradigm. You want to treat these patients, let's say, to organ transplantation. You can actually cure people, but for a time being that people are immunosuppressed, you need to avoid any reactivation of latent infection. And in this case, actually, TB, for the reason of the 2 billion people latently infected, is actually the #1 target, should be. I mean, not only in the developed country, let's say high income, but also middle and low income. And so I think that we are faced now with an increasing number of comorbidities that actually require an accurate diagnosis, detection, and accurate treatment of latent infections, first of all latent TB. Because I think that anti-TNF-alpha treatments have been the clear example that we cannot pay the price of active TB for using a drug like that. But these drugs actually changed the life of these people. And so I think more and more now comorbidity are becoming important in addressing the fact that they might be the real key factor for producing a net health benefit for these patients.
So at this meeting, we heard presentations by Dr. Bob Wallace, for example, about the immunology of anti-TNF, from Dr. Stefan Cadola regarding the immunology, the immunopathology that you're talking about. And I thought it was really interesting that ankylosing spondylitis is more of an inflammatory problem, whereas rheumatoid arthritis is more of an immune effector problem. But all of these illnesses have in common that they depress the immune response, make the opportunity for the TB to reactivate more likely, and of course the IGRAs are immunodiagnostics. So they, to some extent, decrease the function or the effectiveness of these tests, but yet despite that, we heard a lot of presentations saying that the negative predictive value held up pretty well. Would you please discuss that? I'd like to hear more about that, about the negative predictive value under various circumstances.
I would say it was a very strong message that came through in the presentations, both of what was presented at this meeting and also what has been published, and that is that the negative predictive value, as it's been evaluated in multiple populations, has been extremely strong, very high negative predictive value.
So how would you use these tests now there we have Dr. Eisman is our clinician par excellence. So what's your advice to use these tests to help in some way with diagnosing the disease, or would you say that these tests are not diagnostic and shouldn't be used at all? What is your take on that?
My late and dear colleague John Sabarbro talked about the tuberculin skin test, saying it is only a diagnostic aid. That is, it doesn't supplant clinical judgment. And I think the IGRA tests are better than the tuberculin skin test in virtually every setting, but they don't totally replace some clinical judgment. It's not difficult for me to imagine someone who's 40 years old who spent his or her life in a community where tuberculosis rates are astronomically high. and they come to your community now and they have, let's say, inflammatory bowel disease. And I choose that because you can't use etanercept, the most benign of the TNF-alpha modifying drugs, and so you have to use one of the antibody preparations. And would you totally rely on a negative tuberculin skin test and a negative IGRA if you were going to start one of these drugs, which not only increase the risk of TB dramatically, but produce extrapulmonary disease that has high lethality if not recognized? So I would reserve for clinicians the right to make a clinical judgment, even allowing for the strong negative predictive value of these tests.
I totally agree. I mean, he's a master clinician, so I cannot say any more than that. I mean,
I'm the oldest on the panel.
From Italy, so it's difficult for me to add anything. But in any case, I think there is no test actually in diagnostic medicine that will tell you the truth anyway. I mean, if you take TB, I mean, culture is not 100% sensitive, is not 100% specific. Even culture, which is considered a gold standard. So I think clinical judgment would always be the critical part for interpreting any test. For IGRA, which are relatively new tests, that's particularly important. So I would strongly recommend that any IGRA result will be put in the clinical context of risk, of benefit, and of interpretation of the test. Having said that, having a negative, true negative IGRA, we have seen today that it's very reassuring for a clinician that probably you are not dealing with a latent infection. And so I think it's just making your job easier, in particular when you get to immunosuppressed patients.
Well, Dr. Kelly, I know that you've had some published experience looking at the discrepancy between the various tests, quantiferon, T-spot, tuberculin skin test, and could you expand on that? What advice would you give the participants about how to approach discrepancies? What is your approach to that?
I mean, you approach discrepancies when you use multiple tests. That's the first message. So if you use only one test, your level of discrepancy will be significantly reduced. So I will say that discrepancies are needed when we are in a phase that we are building knowledge on new tests. So our study that we did multiple comparisons in different populations of the skin test and 2 IGRA tests. That's not the real practice, in my opinion. So you will not do all the tests in all your patients. But that's needed because in a context of a control study, you need to understand how much they differ. And actually, in the end of the studies, I would say that the 2 IGRA, they agree much more between the 2 of them than they disagree with the skin test. But again, for clinical practice, I'm not sure that I would recommend anyone to use multiple tests to diagnose the same condition.
I'm really glad to hear that, because you agree with the United States government now.
This is probably wrong.
The Center for Disease Control recommends that you pay your money and take your choice. Study the situation and use the test that you like. It's interesting because that's not there are many guidelines written, as you well know. You've written some of them. And there are some guidelines that say, do the tuberculin and then follow with IGRA, or there are various combinations. But the CDC says, no, don't do that. Could you discuss that a little bit?
I love US, I mean, honestly. So but it's not because of that. I can see some situation, and sorry for jumping again to the pediatric situation today. And we have seen the pediatrician, they told us today, when you have a very small kid with a highly risk of latent infection, even active disease, you use any test. You take any positive as a positive. But that's a different clinical judgment. In other words, when you get to extreme situation, I understand that you try to get information from any test which is available. But for the routine screening or for the routine use, I think that combining multiple tests has the risk of increasing, in the end of the day, the costs and complicating the interpretation of the test. That, by definition, should be kept simple.
That's a good subject I'd like to pursue further. The initial tests that were done by Celestis before the test was presented to the FDA, they did several hundred studies and then with quantiferon, then did a skin test, and 5 weeks later did another quantiferon, and there was no change. It seemed that was well studied, but that's really been taken apart, hasn't it? Could you expand on that a little bit? What is your take on how to work it when there's an when someone has not followed Dr. Rickeldi's advice and done both tests? How do you interpret those data? What do you recommend?
Well, you always fall back when you're interpreting a test on your clinical judgment. You know, we can never take that away. So if you have a low-risk individual who had a skin test place followed at some time point by an IGRA, there is a possibility that there was an effect on that IGRA. It could be positive and could potentially be a false positive. But you still have to go back to your clinical judgment. In a low-risk individual, I think that we need to kind of come up with algorithms on how to deal with this, because it's going to start happening. As people, they don't believe their skin test results, so then they go ask for an IGRA. But now it's been done after the skin test has been placed. And we now can see, there are multiple studies now. In fact, every study except Luca's has shown that there is a boosting effect when they've looked at it. The issue is, in all fairness to Luca, is that when you look further out, you don't see the effect. And in your study that did not see, or studies that did not see an effect of the skin test, it was probably looking after the time that it has come back to normal. And a very important study that measured the IGRA response after 3 days, and then going all the way out 7 days, out to 84 days, they started to see increased interferon responsiveness after 3 days. So that's a practical issue. If that's true, if that's something we can generalize to, then if you put a skin test on day 0 and you come back and read it at 48 to 72 hours, based on those data, you could theoretically draw the IGRA at that time and not have an impact.
I wanted to explore a little further the idea of comorbidities and talk a little bit more about anti-TNF. Anti-TNFs are tremendously powerful, useful medications. And I wanted to explore more the concept of who to provide preventative therapy to and how to do that, and what your recommendations are for the interplay between starting the chemotherapy for tuberculosis and starting the chemotherapy for the anti-TNF. And we had some opinions expressed. I'm not sure we had an awful lot of data, but I'd like to hear, we'll start with Dr. Rickeldi. What was your take on, or what is your advice to the people who are listening for how to use anti-TNFs vis-a-vis tuberculosis?
I would say that when you have a patient that has a disease for the treatment of which you are planning at any time to get some sort of immunosuppression, it makes sense to have a clear picture of the potential problem in that patient. So in other words, if you have a patient which is undergoing maybe bone marrow transplantation, you want to have an information about any latent infection. And that's current practice. So you want to, in the medical record, you want to know about hepatitis B, CMV, and latent TB infection. And that's the same for patients undergoing potential candidate for anti-TNF alpha treatments. So we should not forget that anti-TNF alpha treatment, alpha-TNF alpha drugs are the prototype of immunosuppressive drug causing TB. But many others, they also can increase actually the risk of TB. And even more than 15 milligrams per day of prednisone for more than 2 weeks, actually, they are an indication for diagnosis and treatment of latent infection. So, in particular, when for physicians taking care of patients that are likely to undergo immunosuppressive treatment, and in particular anti-TNF alpha, I would say, I would strongly recommend to use the most reliable test to get the information which is crucial. Is this patient latently infected with TB or not? After that, I think that the timing for starting anti-latent TB infection treatment and anti-TNF-alpha is not clear yet. Today we have heard, and also yesterday, that maybe few weeks that can be enough, so 3 to 4 weeks. I think we are still in the empirical area, but I think that the crucial information is to acquire the information if that patient is latently infected or not.
One of the presenters suggested that even 1 month of INH wasn't sufficient. It kind of struck me because it seems counterintuitive to me. I think if you screen the patient, you're sure that he or she doesn't have active tuberculosis, only quiescent or dormant or latent disease, that starting INH for a month should be protective. I was struck in the audience is a very sophisticated researcher, Robert Wallace, and one of the observations he made is that paradoxically that giving a TNF-alpha inhibiting drug may in some ways biologically expose TB in the body to rapid elimination by chemotherapy. And I asked him afterwards if he thought that was still plausible, and he did. And it seems reasonable to me because you say, I'm allowing the organisms to start to replicate in an extracellular milieu where they're more vulnerable to treatment. So I would think that if at least a month several weeks or a month ought to be sufficiently protected. The thing we haven't spoken about is the fact that at least 10% of the tuberculosis in the world is INH resistant. And as we move these TNF-alpha agents to countries where there's more INH resistance, we may not be as protected with INH as we would hope to be, but that's another mountain to climb.
Well, there were several comments made at this meeting, no presentations, but several comments about the new regimen with isoniazid and rifapentine once a week times 12. And I was wondering, how does that strike you? Are you ready to jump on and do that, or what?
I have thought for maybe the past 6 or 8 years, based on various studies and meta-analyses, if we can bring meta-analyses up again, or decision analyses, that a short intensive regimen using a rifamycin is going to be superior to INH, partly because you have attrition for INH. Every month the patient is supposed to take it, the likelihood of dropping out goes up somewhat. And then you add to that INH resistance. And I would go to Jacques Rousset's work in a mouse model, which is that rifampin inherently is a better sterilizing drug than is INH. INH has dramatic early bactericidal activity, but I've always thought a rifamycin should be a superior agent for treatment of latent infection. So it's very appealing to me. One of the things I think is important, though, if you use that regimen, once weekly isoniazid and rifapentine for 3 months, you don't have much room for non-compliance. So I think my sense is that probably ought to be done under direct observation for the near term.
Dr. Daly, any comments?
Well, I would just echo that. That was shown to be an effective and well-tolerated regimen, but it was given under direct observation. And it probably is getting close to the minimum amount of drug and doses. So if you miss a few doing self-administered, I think it's highly unlikely we'll see the same efficacy. The other thing is, which relates to what you just said about isoniazid resistance. I agree that rifamycin should be there, but whether rifapentine once a week for 3 months is going to treat, or prevent, I should say, isoniazid-resistant disease from developing, we don't know. So.
Well, there are 2 things I'd like to say about that study. Number one is, clearly, you're right. It was all done by directly absorbed therapy, and the recommendation is it's hard to remember to take meds once a week, so you should use it as directly absorbed therapy. That's number one. Number 2 is that there was enrollment at multiple sites, several of them international sites. However, they systematically eliminated patients where the source case was resistant to isoniazid. So those patients were not part of this study. But the other point I'd like to make is that the study sample was huge. It was 8,000 subjects enrolled. So I don't think we need to worry so much about side effects coming up later on because the sample size was so big. But we do need to worry about the kinds of problems that have been commented about, particularly if we talk about a global utilization. Dr. Ricaldi, what is your take on the study? You ready to use it in Italy or not?
No, not yet. And also we need to remind that that regimen has not been tested yet in the most vulnerable population, which is HIV infected. So those data, they still need to be confirmed in that people living with HIV. Although I think that is big, I mean, we clearly need to move out from 6 or 9 months of isoniazid, because that's very clear that that regimen is not going to be sustainable for mass scale treatment of latent infection. If we go back to what we were talking about at the beginning of this session, that without treating latent infection we are not getting rid of active TB, that's very clear to me that with the current regimen, which is 6 or 9 months of isoniazid, that would be extremely unlikely that we'll get the target. So I think it's a first step towards the right direction.
Well,
can I just comment that in fact they did enroll HIV?
Yeah, I was going to say that too.
Yeah.
But it was a small number. There were several hundred.
It was not only HIV.
There were a few hundred people in that study with HIV infection, as opposed to 8,000 that were HIV negative. So you're right. The number was small. It probably does need additional studies, but there were several hundred people with HIV, and no indication that it was a problem. But I think you're right. As a conservative physician,